study stuff where we're going to solidify all the things we've been studying, all the things you know. In the block 1 or the lab section of Canvas, there is a lab Word document, and I also created a PDF that's fillable. So if you're somebody who needs to write to learn or to stay awake, you're tired, you're thinking about hormones, you can download that real quick. You don't have to turn it in. For those of you that just are auditory learners and are sick of looking at your iPad, you can just look up today for this case. So I'll let you download that. Somebody asked me like how, when I say draw it out, what that would look like on your blank piece of paper. So I'm going to do it for ACTH really fast. Typically I ask you guys questions and you guys help me get to the answer. That's more fun. But because of time, I'm just going to tell you. So we have enough time for the case studies. Which isn't as much fun for me, but we'll do that. Nakata, Gonzalez, sorry, you guys are like at the end if you want to scoot in. If you're like, I got this, you don't have to. But this is, I am not an artist. Like Clint Corkers knows, I get messy on the whiteboard. But this is what you could potentially do on your white paper before you start the test. And I'm going to show you how to do this. It tells you exactly what the labs are supposed to be, RADs, and maybe treatment if you get creative. So ACTH cortisol feedback loop, Cushing disease, ACTH dependent. Problem is an adenoma, 90%, right? Or a lung cancer. So when this adenoma is misbehaving, it's creating a bunch of ACTH, right? And the adrenals do exactly what they're supposed to do. Do what? Excess, yeah. Now the lab isn't cortisol, it's the dexamethasone 24 hours and all that, right? So, then we have the same thing with here. Does the same thing. You have a tumor, a cancer somewhere in the body, does what? Excess ACTH. The adrenals do what the adrenals do and produce excess cortisol, right? So my labs are right here. If I say what are the labs for someone with Cushing disease or ACTH dependent hypercortisolism, they're right here. We know this is high through our initial labs. And what is ACTH? High. You don't even have to think about it. You don't even have to be like, where's the problem? It tells you. Now, you could also tell you what imaging do you do? So where do I do the imaging? Or MRI first, right? Because 90% here. That's normal. Where do I do the imaging? CT, abdomen and chest. I won't give you an option of abdomen or chest, right? We're looking for the cancer. So this right here tells you everything you need to know, besides obviously signs and symptoms and the specific labs for hypercortisolism, okay? Real simple, you can draw that, it takes a few seconds. Now, with Cushing syndrome, the problem is a little different. We have to know that it's bilateral hyperplasia or adrenal adenoma, or again, someone's taking excess cortisol and unintentionally we're causing Cushing's, right? It's excess. So what happens? Cortisol is high. And that's it, right? Because what is ACTH? ACTH would be what? Low. Because it is working. Pituitary is working. So then, I know, I'm telling you on the test someone has hypercortisolism based on labs, and they have Cushing syndrome or they have ACTH independent hypercortisolism. What's ACTH? Oh, you don't even have to think about it if you draw this out. You should maybe double check it. It's iPad and whatever, but yeah, so you know that it's going to be low. Also, where do I do my imaging? Here? Yeah. How do I treat it? Maybe surgery here, surgery, a prescription, or taper. Taper the disease. And then there, that's all the things you need. One little. Okay, hopefully that's helpful. It's really simplistic. I'm not an artist. I can draw a costume or make a costume, but I cannot draw. Is that helpful? Maybe. All right. You can do that for adrenal insufficiency if you want. I would recommend doing adrenal insufficiency on a different stick figure, but well, that's how I would draw it out. If you're stuck. If you're not stuck, then there you go. All right. So everyone, that was enough time to get your lab, your PDF, your Word document, hopefully. Okay. So this is a participation case study, right? We're not in the lab. We are, now I'm honestly got really sad about that. I didn't gain weight in college. I did in PA school. But don't worry, phase 2 is better than phase 1. That's not an iPad thing. That's a PA school thing. So it'll come back. All right. Or you'll get your life back. So, a little. All right. So, the lab, the case studies. This is your opportunity to participate, and every single one of you gets to participate. And like I said at the very first lecture, the more you participate, the faster you go. You either get lucky and you know the answer, because maybe you have your notes open, or you just studied thyroid disease last night and it's fresh in your head, maybe the thyroid question, or you get lucky and you guess right, or you get unlucky and you have no idea what it is. Or does anybody here just go blank? Like you know the answer, but when you're asked on the spot, when 60-something of your peers are waiting for you to answer, you go blank? Yeah, that was me. But you have to figure out how to work through that, especially when you get to phase 2. And there's like a surgeon attending, or for me the surgeons were nice. It was my inpatient month that you had to be on my A game. So again, get used to getting put on the spot and accepting that you don't know everything. And then, but the beautiful thing about this participation scenario is you have your friends. You can phone a friend. So the person next to you knows the answer. They're going to give you a shot to try, and then they'll help you because we don't want to go. Who do you guys have next? Ortho. Oh, okay. We don't want to go into ortho. How is ortho? It's your last block. The foot, right? I like the other one. Okay. All right. So case 1, and I will post these PDF and PowerPoint after, but I don't post it before because I want it to be a surprise. And again, it's interactive. And you will see that in a second how each of you gets to participate. Okay, so Gertrude Channel. She's a 23-year-old female, presents with a 4-month history of increasing fatigue, feeling jumpy, and has episodes of shortness of breath. She reports that her heart races during physical exertion. Over the past month, these symptoms have progressively worsened. She now experiences them even when climbing stairs or carrying her 2-year-old daughter. Before I go on, remember these cases are going to be harder than what you get on the test because we're building. And again, everyone is everything, yeah. All right, so what systems, I don't know who wants to go first, what symptoms, so think review of systems, right? What systems do you have in your differential? So like, what system, what's in your differential?
Thyroid.
But bigger than that, what does thyroid fall into? Yeah, what else? What they have, this is what they have. What's another? So yeah, home, okay, what else? Cards, yeah, as a group, what else? Neuro, yeah. Maybe like shortness of breath can be heme a little bit. What about sight? Feeling jumpy? Yeah, maybe. Okay. All right. She was recently taken a leave of absence from her job as a waitress because of significant hand tremors that cause her to spill coffee frequently. She reports increased irritability and has been arguing more with her husband over minor issues, including frequent disagreements about the house temperature, which he says is always too hot. She's also lost 10 pounds despite good appetite, and her menstrual cycle is much lighter. That's a history. I can't put all of that on the questions, don't worry. But yeah, that's like, she's filling you in. All right, so we have a pretty solid history. What do we do next? Before the lab. Yeah, you're good. I like it. I like the lab. I like using that. Okay, do we like her vitals? Are we worried about them? What do you think? Heart rate, yeah. 130, we could maybe compare what her weight was last time to confirm that weight loss. All right, so she's a thin woman. She's a fidgeter. Warm skin, no lesions, normal turgor. Vision looks good. Neck, here we go. Thyroid is non-tender, diffusely enlarged and soft. No nodules or lymphadenopathy. A bruit is noted over the thyroid gland. Cardiac tacky but regulating rhythm. No murmurs or gouge. Lungs, abdomen is normal, and neuro. DTR show a rapid relaxation phase bilaterally at the patella. Okay, painting a picture here. What tests do you want to order for this patient? TSH. Besides the EKG. TSH. What else? Yes, BMP, CMP. What else? We have TSH, CMP, BMP. What else? See, we got that. Yeah, what else? We can stop it at TSH, yes. T4, why? We can order T4 for sure. Can we order T3 for this person? Yes, because we're thinking they're in this hyperthyroid state. Perfect. And then I'm going to try to repeat everything you say in case someone has to listen later. I'd also do a pregnancy test, okay? What imaging, not necessarily you have to do now, but what imaging is on the back of your mind? Ultrasound, thyroid ultrasound, maybe a radioactive iodine scan too. Okay, so thoughts about this EKG? Don't worry, there's no EKG, I didn't know. I'm scared. Heart rate is 126. So we're gonna say it's just sinus tachycardia. Oh, my last, was it 2 months ago? I had an A fib up there. I pulled up and like, oh, that's wrong. Anyway, okay, so here's her lab. What do you see? What do you see for last? Tell me. Low TSH. Okay, so we'll first just, what do you see? So low TSH, T3 and T4. What do you notice about that? Yeah, anything stand out about that T3? Really high, right? Yeah. So just based on that, what's the problem? Not the diagnosis, but what is a concern? What's like those high values? You don't like those, right? Yeah. Hyperthyroid. Yeah, exactly. I know it's hard because it's so obvious, right? But she's not pregnant. We're good. All right. So right here, you tip. What is our differential? This is the worst part about ClinCore, right? What's our differential? Graves. Yeah. What else can cause hyperthyroid? Yep. Yes. So any of those thyroiditis is perfect. So we have just subacute, we have Hashimoto's, all of that. Perfect. And we'll come down to why one is a little more like higher on the differential. Everyone agree with that? Thyroiditis is itis? I don't know. And great. Okay. Oh no, not too far. There we go. Nice. Get in your space here. Okay. So we did a scan. We're in a place where scans are pretty easy to get. So we're in the hospital. So we just kind of like, again, we don't need a scan or ultrasound to confirm this diagnosis. What's your number one differential now that you see this scan? The high T3, high T4, low TSH. And hers is the one on the left. So normal's on the right and the left. What do you think? We're thinking either Graves or thyroiditis. What do you think? Graves, perfect, yeah. That like right there, that's like, remember what's the pathophysiology of Graves? It's an autoimmune disorder where the receptors kick up and you have excess activity, excess hormone, which is why the T3 is so crazy high. Good job. So all those things push Graves. Okay, so hallmarks, I guess I gave you the hallmarks of the condition, right? T3 is much higher, right, than it would be in thyroiditis. We talked about the RA scan. Think physical exam. What would someone with Graves have on physical exam? Oh, you're done. Yeah, I know. Okay, you can team up. Okay, yeah. Okay, so we have the eye symptoms. What else? That's like the big one. The bruit, yes, the bruit and the goiter. Not everybody has the goiter. Yeah, but you definitely can, and that's because that hyperactivity. And I forgot you did. So you're off that. So the eye symptoms. There's also like the skin changes that you can see as well. But again, I'm not going to put a slide up and be like, what is this? It will be part of the picture, part of the case to get you to the diagnosis. Do we need to do any additional labs? What else? This is extra credit. What else do we do? We're thinking it's Graves. What do we do? Lipid. I like that because they can have high cholesterol. Yeah, what else? Antibodies. Perfect. We're going to do the antibody panel to find out, like, to really help confirm that. Okay. Sorry, okay. So she was ultimately diagnosed with Graves' disease. Good job. You guys treated your first patient of the morning with radioactive iodine-131 ablation, right? That's the definitive treatment in the United States. There are medication options too, so make sure you know that there's medication options. And then we talked about yesterday all the meds that we use for Graves' patients until they can have the ablation, okay? Beta blocker, the steroids, and then the antithyroid meds. Okay, 2 months after treatment, she reports feeling much better, returned to work and normal activities. However, she did not attend her follow-up appointment because her symptoms had resolved and life got busy. Welcome to Florida. This is a Florida picture right here. Okay, so we're still with Gertrude, and 2 years later, post-ablation, she comes in with a new set of symptoms. She has persistent fatigue, dry skin, constipation. Over the past several months, her menstrual cycles have become irregular and heavy. All right. Let's do a physical exam. Okay. Blood pressure a little high, yeah. Heart rate is not the same. Now she weighed 130 before. Now she's 150. Otherwise, physical exam. We have dry skin, some thinning hair. Eyes are okay, no goiter, right? We have no palpable thyroid. Lung and cards exam. Oh, neuro shows DTRs and delayed relaxation phase. Okay, we're painting another picture, right? Not just with fatigue. We have lots of things. So, what is highest under differential? Yeah, hypothyroidism, right? We created this, right? We ablated her. So would that be primary or secondary? So it's secondary to the ablation, but the primary, the thyroid doesn't, yeah. So I don't ask you that, I'm not going to. Okay. But again, it's primary because this is the problem. The problem is not pituitary. Maybe I could ask you that. The problem is there's no thyroid that works, right? But it's secondary to the ablation, but technically it's primary. What test do you want? Which one? TSH. What else? T4. I don't have to do T3. Should I make sure she's not pregnant? Someone said lipid, CMP. She's gaining weight. What else could be? Like A1C, yes. That's extra credit, thinking ahead. She's bradycardic, maybe an EKG. Okay. Okay. So you have our 2 to 4 tests. We do your labs, because it's endo, physical exam, history is done. We do our labs. And what do we see? The EKG shows bradycardia. What are those labs? Read those out to us. You're up to it. Yeah, what do you see?
TSH is high,
yeah.
T4 is
low. Yeah. So, what is your primary diagnosis? Did it change?
No. Yeah,
still hypothyroidism, right? Right, the failure is primary because of the thyroid gland doesn't work. Well, we're here. What are signs and symptoms of Gertrude now that correlates? Why are you not surprised that those labs showed up like as hypo? What was it about her physical exam? And I can go back. That points to hypothyroidism. The dry skin, yeah. What else? Thinning hair. Yeah. Yes, DTRs, bradycardia, lots of things, right? I painted a nice picture for you. you know she's not hyper. Even if you didn't know about the ablation, it's not hyper, right? So here is all of the things flagged of why we're thinking hypo, from her history, from her physical exam, all the things. Okay, what's the cause of this? We kind of already said this. Okay, the cause is the ablation, right? The thyroid doesn't work. What do we treat her with? Yeah, levothyroxine. How long do we treat her? Forever, right? Yeah, forever. Okay, when I give her levothyroxine when do you want to see her back? Roughly. Yeah, a little longer, so 6 to 8 weeks. And I'm monitoring her long time. What do I do when she comes back? What kind of labs do I check when she comes back? TSH, yes, TSH all day, T4 if you're lucky when you're in the military. Okay. What patient education? So she's never been on levothyroxine before. She didn't take PHARN or Endo in PH schools. So what do I need to tell her about levothyroxine? Okay. Yeah. Okay. I like it. ER. What else? Yeah. Yes, we need it fasting. We need to build over time because endo is slow. Just like when the adrenals take a nap, we need to wait a while, do it the same each time, and not with food, right? Okay. What about supplements? I can take it with my calcium. No, nothing. All right, you guys feel good? Thyroid's pretty straightforward, obviously hypo. Don't forget about the thyroiditis. Don't go crazy into goiters. Obviously, there's like one goiter that I really talked about treatment for. I told you I got rid of my fun cancer question. Those two base 2 weeks. But again, no excuses. Okay. So, okay. All right, phase 2. Cortisol is a 35-year-old woman who presents for routine physical exam and is found to have elevated blood pressure, 188 over 112, pulse 82. Previous visits, her blood pressure is 160 over 94, 158 over 92. So can we go ahead and say she has hypertension, right?
Yes.
On further questioning, the patient reports experiencing episodes approximately twice a month characterized by sudden onset of apprehension, severe headache, excessive sweating, rapid heartbeat, and pale face. These episodes are abrupt in onset and typically last 10 to 15 minutes before resolving spontaneously. What a good history you guys got on her. Yeah. Okay. So we know that breast cancer, can we diagnose her as hypertension? Yeah, sure. Okay. This is for we can go these three together. What are endocrine and non-endocrine causes of secondary hypertension? Hyperaldosteronism. What else? Hypothyroid, yep, and hypo, but yeah, either one, so thyroid dysfunction. What else? There's 6, and you can even say non-endo. Okay, what do you think this is? What is it? FeO, yeah, so FeO, Cushing disease, Cushing syndrome, acromegaly, hypercalcemia when we get to that, so lots of good stuff. What about non-endo stuff? Renal stenosis, maybe OSA, COAR, all those fun things that won't be on. Okay, so we get a good history. We're going to do a physical exam. Good job. 30 minutes later, we repeat her blood pressure just in case it's still high. Remaining physical exam is unremarkable. And before coming in, she completed a few labs. So let's look at those together. All right. This is what labs looks like in Ulta. Okay. So what do you notice on these labs? Yeah, unremarkable, right? Okay, great. This is again, she had that before she came in. So, based on history, physical, initial exam, what is highest on your differential? Theo, yeah, still Theo. Okay, so which of the signs and symptoms led you to believe it could be excess catecholamine? Yeah, paroxysmal, episodic. She came in with known hypertension, but and not everybody with Theos have a known hypertension, but she came in, and the key is it's paroxysmal, episodic, where there's 4 classic things. Obviously, they can have anxiety, tremors, all that, but what are those 4 things that really stand out? Headache, hypertension, diaphoresis, palpitations, right? All that good stuff. But you guys saw, like, you see the picture, right? You saw what I was getting at. You see that painted a very, hopefully, clear picture. If it didn't, that just means you haven't got to lesson 16. Here's your key. So, right, I'm not good. These people, they can live their lives just fine and go under anesthesia and then catch the Theo. Again, 50% of these people are asymptomatic. Am I going to give you an asymptomatic Theo on the test? No. What? No. I guess I could, but probably not nice. Okay. All right. What additional labs would you like to do for Emma? So we have a CMP, thyroid, all of that is fine. We're thinking it's Theo. What labs do you want to do? I know you're filling up the thing. What labs do you want to do? If you get stuck, Epinephrine. Because what is excess? What hormones are excess? Yeah, epi, norepi, right? Our fight or flight stuff are high. Awesome. So just as a group, we did the CBC, the CMP, the TSH, T4. Why do we do TSH and T4? Kind of hyper, that would easily rule that out, right? You don't have to memorize the workup labs, but I just want you to get why you're not just jumping to free of medicines, right? You're doing like a bunch of labs. Make sure she's not pregnant. Maybe your analysis, I don't know. Okay, because again, she's hypertensive too. We refer her to endocrinology, but we have to manage her hypertension too, right? So we put the referral in and we get these labs back. Go ahead and what do you see with these labs?
Nephrins are high.
Yeah, high metanephrines. Yeah, we repeated like the electrolytes. Yeah, I know it's busy. Yeah, high metanephrines. She's not pregnant. Yeah. Okay. What could you consider, right? We think it's a Theo, everything, but what could you consider? This is for the group. What could you consider as a confirmation lab? 24 hour urine, right? And sure enough, that's high. And then here is the slide. If you helped, if you needed help with why. Okay. All right. What's your diagnosis? Theo. I feel like that's a very good question. I know. Okay, so, and this is why, right? All of these things tell us why, from her history, her labs, her urine. You guys are doing great. Okay, what is the imaging? What imaging do you want to do? CT, non-con. Love it. Yes, CT, non-con. Okay, what if, for the group, what if the CT was normal? This is out of the test. This is extra credit. What else could it be? Yeah, MRI, or those perigangliomas that I'm not testing you on that can also exist. Usually do like a CT of the chest. That's extra credit, so don't stress. But it's the periganglionoma thing. All right. So we do the non-contrast CT, and we see a mass on the adrenals, on the left adrenal. Where are we sending her? We said endo, but yeah, surgery, right? Okay, so what 2 medications, we have 2 of you, what 2 medications are used prior or until surgery to manage that hypertension and that tachycardia? Alpha blockers. So yeah, so which one do I do first, beta or alpha? Alpha blocker, what? Yeah, so a alpha blocker and calcium channel blocker first, right? Why? Beta blockers will totally help with the tachycardia, but why? That we want to prevent the hypertensive crisis, right? So that unopposed alpha blockade. So that's on the slide. If you don't, like, you can memorize AC before B, but the medicine behind it is on the slide too. Okay. What are the medications? What are alpha blockers? What are beta blockers? All. What are calcium channel blockers? Good job. Okay. All right. What's the mechanism of action? No, I'm just kidding. I don't do that. No. Okay. All right. Next we have feel good about our Theo patient. I'm never going to see a Theo, but I just think it's easy and fun to teach. Feel good about Theos? Okay. All right. So it's not on the test, but again with Theos, you have to screen them for cancer for a long time. They're managed for a while. Okay. We have pituitary. Pituitary is a 7-year-old female. Yay, he's scared. Okay, so we have a 7-year-old female presents for routine sports physical. Over the past 3 years, she has experienced rapid somatic growth. Her mom reports a 6-month history of axillary and pubic hair development over the last 6 months. Increased body odor, so she's already needing deodorant. And her mother is concerned and asks whether these changes are part of normal development. I know you guys haven't had PE, so as a group, do we say this is normal for a 7-year-old?
No.
Probably not, right? Technically, it is normal development, but it's happening too early, right? Yeah, so yes, we all go through these things, but not necessarily at 6. So it is not normal development. Okay, so we review her record, past medical history. She was a full-term infant, no complications related to birth. From 9 to 18 months of age, her growth tracked at the 95th percentile. Okay, so she was always a big baby. But by age 2.5, her height was equal to that of a 4-year-old. And both parents are tall, so we could see like, oh, nobody really didn't raise any flags. But now, mom also reports development of facial acne around age 6, and which is earlier than her older sister experienced, right? So it's standing out. Okay. This is hard. Okay, what's your differential? There's 2 to 3. What's your differential? Growth hormone? Yeah. What else? Gigantism, but I won't put that on the test. Yep, because of the high growth, right? What else? There's one disorder that has excess androgens. Do you remember? It's like buried at the very bottom of lesson 5. CAH, congenital adrenal hyperplasia, right? But yeah, excess growth hormone, gigantism, maybe some cortisol issue, genetic issue for sure. Like, yeah, okay. That one's hard. So we do a physical exam, and again, she's tall. Consistent with the average for a 9-year-old. So she's tall. So she's essentially, the growth chart, she's like 2 years taller than what she really should be. But well-developed, well-nourished, no acute distress. Tall for her age, but is well-proportioned and muscular. We'll talk about what that means in the next block, especially for males. Mild face acne. We do a GU exam, and sure enough, there's some fine pubic hair, so Tanner stage 2. She won't be tested on, but she's having like puberty development early, okay? Normal external genitalia exam, because that's all you're going to do on a little kid. It's just an external exam. Neurologic exam is normal. All right, so what is the primary problem? Remember, all I need you to be able to do for CAH is identify it, okay? Not treat it, but what's the hormone issue here with congenital adrenal hyperplasia? Excess what? Keep going. What else comes out of the adrenal? Androgens, yes, androgens. So it's an androgen excess because of like she's appearing like she's like days away from her menstrual cycle or menarche, right? So so it's androgens. Okay, so again, this is like a breakdown that you potentially use to study, but excess androgens, so that's your male sex hormone production. So that there's more than just this going on with her height and stuff. It's probably multiple hormones. But again, the big thing I'm going to give you is the secondary sexual features, and then all of that stuff. Okay, and again, androgens are also released from the adrenal. Okay. Knowing what you know, we're going to talk about androgens so much more. Block 2 is really fun. What laboratory tests do you order for this patient? Wait. What labs do we order for this patient? If we think androgen, so let me make sure I don't ask for it either. Yeah. What is, with this, think of the problem of, 17-hydroxyprogesterone. Perfect. And then you can also, extra credit, I would definitely do FSH and LH, and testosterone, if it were, and then for sure an estrogen. Okay. So CMP, CBC, all of that. I do an IGF-1 because of the growth hormone excess, right? I would do all of that. Maybe look at cortisol. What if I'm worried about cortisol? What tests do I do? Cortisol being high. I think not. I see a patient and I think they have signs of excess cortisol. That's not a suppression test. Converter. Okay. For this one, it's 17-hydroxyprogesterone, testosterone, estrogen, FSH, LH. Okay. What do you need to know for the test? 17-hydroxyprogesterone. Okay. So here's your labs. How would you interpret this? Yeah, what type of T is high? LH, what do you think? Yeah, we're not going to really read it, but it's a little low, maybe normal. But what about her 17? So the OH is hydroxy. 17-hydroxyprogesterone is a higher one. High, yeah. So what? That's how we interpret it. What is the main? What do we know for sure? What's the congenital adrenal hyperplasia? Perfect. CAH. So what are the two types of CAH? Classic and non-classic, right? Which one do you think this patient has? Yes, because of her age, right? Because again, what happens in CAH is what? There's the enzyme deficiency, right? What is the enzyme that's deficient? Is it 17-hydroxylase? 21-hydroxylase, right? Yes, okay. How would classic have presented? If it was in classic, they have a complete deficiency in 21-hydroxylase, so they never get to cortisol. How would they present? Yes, the age, would they be younger than this patient? Yeah, a baby. And they would probably, they could not make it. They could also have ambiguous genitalia, the viralization, because they never get to cortisol, but they have all the 17-hydroxyprogesterone excess. And what does it do? It goes to androgens and they get viralization. So the patient was not classic. That would have just determined as classic. So great question. Okay, did we ask all these? This is a fun one. You guys are really probably very sad-eyed stuff that's going on. Okay. Let's look at that. Two types. We know the enzyme. One with the enzyme, with one it's completely deficient, other it's partial. All right, I know. I think when I was making these last semester, maybe it was on the radio. I don't know. Okay, where do I send this person? Endocrine, right? Yeah. What do you guys? We don't talk about treatment, so that's next semester. We'll skip that. It's oral contraceptives, prolactin. All the rest are for your situational warrior. But again, we're going to try to get her to normal growth. We don't want her to be gigantism. We want to address that. We want to address the viralization and all of that stuff. So that stuff you will learn later. Okay, so I'm at, you guys want to do another thing? We're at 35. We push? Okay. Okay. So again, CAH, don't be overwhelmed. It won't be such a big case that they won't be a giant and it will be obvious. Okay, I hope. And then you all remember, identify it, either diagnose it, know the labs and the enzyme deficiency. That's all I can potentially test you on. All right, so next patient. Glandy Lyon is a 27-year-old woman who presents with depression, insomnia, puffy face, trouble losing weight, and recent increase in facial hair. Okay. So on that for a second, we're switching gears. Her menses has been irregular since they resumed after the birth of her child 10 months ago. She's not breastfeeding. She's not currently taking any medication and denies any illegal drug use, tobacco, or alcohol use. All right, over here, what is your differential? Yeah, Cushing's for sure, yeah, good job. What else as a group could be on here? Postpartum, right? Yes, I love that, postpartum depression. Cushing's because of like the puffy face, the weight, the facial hair. Could be something we're going to learn about next class, which is hirsutism, PCOS. Could it be a thyroid issue? Could she be pregnant? Good job. Differentials. You guys are doing so good at that. Okay, she has done labs within a few weeks prior to her visit, and the CBC and CMP were unremarkable. Okay, her pregnancy test negative, and you go see the patient. How are her vitals? What's off on her vitals?
Hypertension.
Yeah, hypertensive. Her BMI is a little high. So 30 is the cutoff for obesity, so she's 31. Well developed, well nourished, no acute distress. Cute. Okay. Obese. Most of her weight appears to be in her abdomen and hip region. Okay. You also note that her face is puffy with increase in facial hair and ruddy complexion. What's ruddy complexion? Like redness? Yeah, I like it. Or plethora. I don't know if I've ever called anything ruddy. Okay. No peripheral muscle wasting or striae is noted. Okay. Which endocrine systems do you think is the patient's primary problem? So think broadly, okay? So not the diagnosis, but like which organ is an issue? Which one? But kidneys, yeah, ADA too. But yeah, yeah, awesome. What's another organ that could be pituitary? Yeah. What else? One more. Thyroid. I like it. Okay, perfect. So we're on. So we kind of, when we think of broadly, we can think of how we're going to pinpoint it. And this is an increased facial hair or hirsutism could be suggested increase in which hormone? Androgens, right? Need more next. Next topic. The depression and puffy face can be in two conditions. What do you guys mean? Thyroid and cortisol, right? Yeah. And then for you again, here we go. So earlier, what are possible causes for her hypertension? This is already answered this as a group. What are possible causes of hypertension in endo? Thyroid, PIA, what else? Aldosterone, Cushing's, all the things. Look how much you guys know. Okay. So combination of, this is, I'm not going to read this, but this is just a breakdown of, so we talked about how her signs and symptoms are this, with the hormone, and this is like the medical decision making down I added. Okay? If for some reason this doesn't click for you, you can read the slide today. All right. So recap. We have a 27-year-old female. She's struggling with depression, postpartum, right? Insomnia, puffy face, facial hair, ruddy complexion, irregular menstrual cycle, hypertension, obesity, that's central obesity, hirsutism. What initial labs would you guys like to order? I need at least 4 labs for this patient. Dexamethasone suppression test. What else? 24, yeah, 24 urine cortisol, TSH with probably T4 or T3 or just T4? T4, but minimum TSH, CMP. What's another hormone I can consider? This is extra credit. HCG, yeah. What is it? Salivary, yeah, the overnight salivary. Maybe prolactin. She's not having she's not clearly having prolactin or galactorrhea, but she's having kind of weird menstrual cycles, the depression, things like that. So I'd probably throw in the prolactin, extra credit FSH, I would call this. Okay. All right. So here's your labs that you ordered. And you say, okay, great, you guys are great. A dexamethasone was given at 11, followed by an early morning cortisol. Why do we order cortisol in the morning? High or no? Yeah. Okay. So what do you read those? How do you interpret this? I can help you. So yeah. So would you say it's abnormal? Yeah, because it's high, right? Yeah. And TSH, what do we think of TSH? It's okay. We did those T3, why not? I guess I wouldn't have, but yeah, T4, we're okay with that. Prolactin's okay. LH and FSH. And then, oh, what about our 24 hour? It's high too, right? Yeah. Okay. So, just cut out all the junk. So there's all the junk. You cut it out. This is what you see, yeah? What additional laboratory tests should be ordered now that can you say this is hypercortisolism? Would you agree with the lab? Okay, what lab should I do next to help? What lab do you want to do next to help point me in the direction of what's going on? TSH was normal, and this is only the abnormal. So high dexamethasone suppression test and high urine cortisol. And yes, for sure, she has hypercortisolism or anemia. What lab will help me determine what to do next? Yes, serum ACTH, perfect. And how do you interpret this? How do you do it? No, front row. Here we go. How do you interpret this? It's elevated. So what's your diagnosis? High ACTH, high cortisol. You had to pick one. Cushing syndrome is an umbrella term. So is it syndrome, disease, ACTH dependent, independent? I know this is a tough one on the spot. The disease, right? Okay, perfect. Great job. Okay, if it's the disease, where is the problem? If you're where do you think it would be? The brain versus yes. Yeah, and so it's Cushing disease because the ACTH is high. If you don't know that, you wrote it down, you did your picture before you started the test, and sure enough, you can confirm it with your picture, right? But the reason is, so with disease, with an adenoma, it's excess ACTH causing the excess cortisol. That's why ACTH is high. Is that ACTH dependent or independent?
Dependent.
Dependent, right? All right, here is your summary of how you know this. Again, money slide here. All right, so what do you want to do? What do you want to send glandulions? What do you want to do? Or order? Yeah, we already did that. Well, we did the 24-hour dexamethasone. We did the 24-hour dexamethasone. So we got 2 of the 3. We did the ACTH. We don't need it. Yep, because that's initial. So our initial lab said hypercortisolism. Yes, exactly. And where should I send it? As I do that MRI. And perfect, good job. And this is we're doing the brain MRI. What treatment did Endo? What do you think it's going to do for this person? I'm glandy, and I'm like, what's Endo going to do to treat my Cushing disease? No, I have Cushing. I already have excess. Yeah, I have. We don't. Let's say the MRI shows an adenoma. Transsphenoidal resection. Yeah, surgery. When do I do meds for an adenoma? Prolactinoma. Perfect. So surgery. And then so just kind of you can show them the picture of what to be expected. Okay, so this woman, if she goes and she gets surgery, what is given post-op, temporarily at least? Steroids, right? Yeah, because we messed up this lovely feedback loop that our body does so well. Okay, this one's actually great. Okay, you can do this maybe. Okay, so we just had a transsphenoidal resection for my Cushing disease, ACTH secreting adenoma. Okay, what endocrine complication can occur after surgery? Yeah, any of the hormones? Yes. What about not anterior pituitary? Yeah. The posterior pituitary. Yeah. Yes, SAAH, yeah. So that, and again, I would have to give you way more to get that, but surgery, especially surgery to what? My pituitary can cause hypopituitarism. It can also cause SIADH and VI. Typically, post-op SIADH and VI is temporary. Okay, we can have a break. I think we only have a few more cases, so I guess back at 8. Oh, because there was a traffic issue. If anybody wants me to redraw, or I can do that. And then again, if you're stuck on adrenal insufficiency, because it's the same hormones, draw that separate. You can do the same thing, not as many arrows, but you could do that same thing. I would just do them separate. You can do it all in the same beautiful stick figure. There, you would be confused, okay? But I'm around, and then I'm around. I'll stop at your lunch if you get a real lunch, and then I think I'm gonna Proctor Cola's lecture for peer review, so I'll be around today. Okay, but for sure at lunch. All right, Gonzalez, I haven't forgotten about you. In the corner, we have a new patient. Okay, adrenal rush. It's a 40-year-old woman presents with a 6-month history of increasing fatigue. What is her initial differential? This is on fatigue. With me, at least 3. We're in clinic 4, right? And so just like think big. Like, well, yes, depression. I like it. 1 more. Amazing big one. What else? What is on the back of our mind in clinic 4 that hasn't yet been? Yeah, cancer, right? Yeah. What else? What are other things? Big review systems. Yeah, so which is what? System. Endo, right. Cardiac, maybe. Home. A lot of things can cause fatigue, heme, all of those things, right? Pregnancy. Pretty much, we're all fatigued. It's all fine. Which row's left? This row. Who did I forget? That row. I know, I can't do this. Okay. I don't know if I have enough questions. We'll try. Okay, so here we go. During this time, so she's coming in for fatigue. During this time, she had unintentional weight loss of 25 pounds. Yeah. She's also noted joint pains, muscle weakness, mild nausea, and diarrhea. Some irritability and feeling on edge more than previously. She states that she has not had a menstrual cycle for 3 months. Okay, what would you say is on, for the 3 of you, what are things that could be on this differential for a woman with fatigue, weight loss, and we're gonna bring it down to endo topics. Hyperthyroidism, what's that? Carcinoid, yeah, I didn't teach that one yet, but yep, what else? What's a condition where you have weight loss and fatigue? Diabetes, Addison's, adrenal insufficiency. Perfect. And what else? Because she's a 40-year-old female, she could still what? Get pregnant. Yeah, right. Yeah. Okay. But she wouldn't have weight loss unless she's puking. Yeah. But obviously, I'm not. Yeah. She could be pregnant and have a no. You're right. Pregnancy is not on my list. It's not an endo thing. You always check pregnancy. Okay. So we do a physical exam, and she is 5'4", weighs 102 pounds. I will add a BMI in the future. Heart rate, vitals. Do we like those vitals? What do we think? Are you worried about her vitals there?
Wildly.
Yeah, a little hypotensive maybe. We do orthostatics and they're okay. Right? We do orthostatics when someone's dehydrated and they're dizzy. We do a thyroid exam, and we know it's diffusely large, and her bowel sounds are hyperactive. Oh man, okay, so do we still like this? What are we thinking? It could be a repeat, but what's still on our list, or do we have anything new on our list based on that exam? So she has a goiter, hypotensive, and weight loss. What are we still thinking? So Addison, is hyperthyroid still on there too, potentially? She has a goiter, she's hyperactive, she's had weight loss. Would you keep that on there?
Yeah.
Would you keep that on there? Yeah. Okay. what would we consider with her weight loss of 25 pounds and 3 months? So regardless of endocrine, what do we think? She's lost 25 pounds. Cancer. Don't forget. But again, remember with this case, she had poor appetite. She had diarrhea. But again, there's still like 25 pounds, 3 months. Yeah, that's scary. Oh, no, close your eyes. Go back. Okay, all right. So, what conditions, or endocrine conditions, should we consider related to the amenorrhea? So like irregular menstrual cycle. Prolactinoma could cause, so excess prolactin. What other endocrine disorders can mess up my patient's menstrual cycle? We got prolactinoma. What else can cause irregular cycle? We've talked about androgens. Yes, androgens can throw it up. What's one that's the biggest topic that I talked about this lecture or this block? The biggest, most slides. I do feel like cortisol, but it's not. What's more common? Yeah, which is what? Thyroid. Yeah, thyroid. Yeah, so thyroid disorder. But Graves is even better than thyroid disorder because of the weight loss and that sort of thing. Awesome. Okay, what tests, you guys? We got 6, so all 3. Woohoo! I need. What tests do you want to order? Give me 2. Yes. What else do we want? They don't have to be endo, but I have a weight loss patient who is fatigued, and yeah, what else? And CBC, CMP. What else? Prolactin. I like it. What else? No, maybe we could think about it, but probably would be like an EKG, maybe a chest X-ray, potentially. Again, because the weight loss is scary. All right, but this is what you guys do. Good job. You get a CBC and a CMP. Sodium is, how would you interpret those? Sorry, I'm not sure. What do you think? Is high? Yep. Yep. She's not pregnant, which we figured. Yeah. And if she, is that hyponatremia? Is that concerning? If I was thinking SADH, what would I need to tell you about her urine, right? I would need to give you some story about her urine, and you guys know what to do with that, right? Okay. So this is what we got. She's got some anemia. CBC says anemia. I just gave that to you. She's got hyponatremia. She's got hyperkalemia. Potassium 5.6. And we already interpreted her thyroid. So are we thinking hyper or hypo? Hyper or hypo? With those lines. Hypo, okay. Which symptoms correlate to the TSH level? Ew. I can go back. So when she can, what is it? Yeah, if she has a goiter. What about, so with hypothyroidism, usually they gain weight. This person didn't, but what else? What was she's the plate? Fatigue, right? Everyone, yeah. So that's one. But the enlarged thyroid for sure. Now, usually hypothyroidism is amenorrhea, so like a heavier cycle, but you can have amenorrhea sometimes. So again, on the test, I won't do that. I'll make it very clear. This is like what you're going to see in real life. Okay. Joint pain, all these things. Okay, here it is. This is what says, is there a thyroid dysfunction? Okay. What other labs may contribute to hypothyroidism? So these lab results. What in here is like, well, that causing hypothyroidism. Anemia, yeah. Look, you guys haven't even taken me months yet. All right, so recap. With this lovely, horrible test, or this case that is very confusing. I think it's the last one. So, adrenal rush recap. So she's 40-year-old. She's got fatigue, joint pain, muscle weakness, and she's irritable. Yeah, I guess I'd be irritable too, right? Dealing with all that. She's feeling on edge. That doesn't fit hypo, right? Her labs indicated hypothyroidism. Weight loss doesn't fit hypo. GI symptoms, she had diarrhea or appetite changes, right? Hypotensive doesn't necessarily fit hypo, but she did have a goiter. Labs show hypothyroidism, low sodium, high potassium, and anemia. Now, I've heard you guys say this, what else have we not done, right? Yes, we have the diagnosis of hypothyroidism, but it doesn't explain all the electrolyte changes. It doesn't explain all of these other things. So what do I need to do? Think hypotension, weight loss, cortisol, because what cortisol, and when do I order cortisol? In the morning. What else do I usually, why am I ordering cortisol? Am I worried it's high or low? Low, right? This is not a Cushing type patient. Yeah, so with ACTH, which I heard you guys say. So we do a serum ACTH, we do a morning cortisol. We do both of these in the morning actually, because they're diurnal. How do you guys interpret this? I got everybody, yeah? Nobody? I missed you? Yes, because we weren't there yet. Yes, we were building. We were building there. We weren't there yet. So like in real life, I wouldn't jump to cortisol because I'm not an endocrine class. I'm in the clinic. So in real life, I wouldn't be like cortisol. I would be like anemia, cancer, and thyroid, and then I think back to my endo class in my junior semester, and then But also, maybe you just get extra credit because you guys are all over it. Okay, so where am I? Oh, okay. So how do you interpret these? High ACTH, low morning cortisol. What is that? Okay. Well, cortisol low tells me that's good. So ACTH is high. Is that something the pituitary is working or not working? It's working. It's responding appropriately to low cortisol. So where do I think the problem is? Adrenals. And so what is that? Primary, secondary? Primary, also known as Addison's, right? What causes Addison's? Autoimmune, right? It destroys the cortex. Or cortices is the word. Okay. What do we want to do? Good job, by the way. That's can be tricky. You guys did really well. What do we want to do with this patient? Yeah. We're going to get a CT of the adrenals, and where do I want to send them? Yeah. Okay. So, what tests do you think endocrinology is going to order to help confirm that this is adrenal insufficiency? What do you think? Cosintropin stimulation test, right? The ACTH stimulation test. I'm going to do that. Do I want you guys to be able to read that test tomorrow? Wait, when? Friday. Friday. No, I just need to know when to order it and why you're ordering it. Okay. Tomorrow, you didn't know? All right. What's our diagnosis? Addison's, which is primary adrenal insufficiency, most likely cause. Oh, sorry, I totally read that way too early. That was not intentional. How do you guys read these? Negative. Yeah, so this is just extra credit. Just most of the times it's Addison's, but there are, it's like where tuberculosis and other things can cause Addison's or primary adrenal insufficiency, excuse me. All right, this is fair game though. How do I want to treat my patient with autoimmune steroids? How do I give it to him? Injections, PO, right? How many times a day? Twice a day, right? Why? Diurnal, right? Yeah. So all this is, goes back to like the basics of how you can use the basics to help you with even treatment. What's education I need to give this person regarding steroids? Safety. Yes. Sickness. I like it. Yeah. yeah, I need a bigger boost, I need IV infusion, all that stuff, I need to go to the ER, exercise trauma. Great job. Should this person wear that safety thing, right? And should I talk to their family about this too, right? Because if I'm taking, I might not catch up on, or pick up on it, right? Good job. What about, this person also had hypothyroidism, right? Remember? When do I see him back? I'm going to give him levo. When do I see him back? Yeah. And then do you feel comfortable if I gave you a TSH and it was high or low, managing their levothyroxine treatment? All right. That's it. That's it for the lab or the case studies. You guys did so well and you participate and you were very impressive, so thank you. Again, in the test, my intent is to make